Good morning, everyone. I welcome you to the February month APA meeting. Sorry for the delay. I had some network issues, so not able to log in with my laptop. So I'm coming in my mobile. Today, as usual, we have two topics. One is the approach to peripheral neuropathy, and another one is ECG neurology. Both are very good speakers, and Professor Mukundan sir is a renowned speaker and known to all. And Professor Dr. Balamurugan sir is also a well-known physician and teacher in Madurai Medical College. So before starting the meeting, we'll go with the physician prayer. Next slide. Next. Physician prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray that you give skill to my hand, clear vision to my heart, and strength to my body. I pray that I will always realize that being a physician is a privilege and honor. With the simple faith of a child, I will rely on thee. Amen. So I request our chairman, Dr. Sivashankaran sir, for the welcome address.
Good morning. Welcome to all our senior members and members of APA and other branches. On behalf of APA chapter, Trichy branch, I cordially welcome our two eminent speakers, Professor K. Mukundan, who is going to talk about the approach to peripheral neuropathy, and another speaker, Dr. P.V. Balamurugan, MD, Associate Professor from Sivaganga, is going to talk about the ECG neurology. So before we are starting the meeting, vote Muthumani for further proceedings. Muthumani?
So minutes of the previous meeting. Last month we had our APA meeting held on January 30th on the web platform. Around 60 members have attended the meeting. As usual, we had obtained accreditation from the Tamil Nadu Medical Council with 1 credit point. We had two topics. One is Dr. Caesar from Tanjavur, who has spoken about Arise the real world evidence. That is regarding the long-acting insulin degludec. And the one more interesting topic is HbA1c, how, when, and why by Dr. Kumarvel, a renowned endocrinologist. We had very good discussion after the meeting. So I welcome Professor Dr. Mukundan sir for this topic. Next slide.
Introduction.
Sir Mukundan sir, good morning, sir. So Prof. Sir is Sir is the head of the Department of Neurology, Stanley Medical College, an eminent scholar, well-famous physician, and enthusiast author for many books and journals in neurology. Many meetings, APA, IMA meetings, most of the meetings Sir has given many interesting topics. சாரோட சிவிஏ பார்த்தீங்கன்னா அதுவே ஒரு 10 to 15 பேஜஸ்க்கு இருக்கு. அது பார்த்தீங்கன்னா எல்லா காலேஜ்லையும் எஃப்ஆர்சிபி வாங்கியிருக்காரு சார், ஐசிபி வாங்கியிருக்காரு, கிளாஸ்கோ, லண்டன், இல்லை 4 ராயல் காலேஜ்லையும் சார் எஃப்ஆர்சிபி வாங்கியிருக்காரு. அண்ட் ஹீ இஸ் தி ஐசிபி செக்ரட்டரி ஆஃப் தி அமெரிக்கன் காலேஜ் ஆஃப் பிசிஷியன் இந்தியா சாப்டர். And he is a fellowship member in ICP, Association of Neurology. He is the executive member, and he received 2 awards, important awards. One is from the V.R. Joshi Outstanding Referee Award 2015 from the Journal of Association of Physicians of India during Epicon 2016. And another one is Frontline Warrior Against COVID-19 in India from the American College of Physicians Indian chapter. Our Paul Brace's book is one of the contributing author. It is a well-known book for neurology localization. அப்புறம் அவரோட பப்ளிகேஷன்ஸ் பார்த்தீங்கன்னா அதுவே ஒரு 20-30க்கு மேலே கண்டினியூஸாக போயிட்டே இருக்கு. ஆக்சுவலாக ஐ ஹேட் ப்ரிப்பேர்ட் a very good slide for his introduction, but due to this network issues, I was not able to tell all those things to the audience. So kindly pardon me, sir. But you are a well-known figure among the physicians and also the non-physicians. So previously you used to give many topics in Trichy API. If you remember, you have given one topic for our Clinicon conference, which is the conference done by the basic physicians and for the primary care physicians. And you also given many topics for the APA Trichy also. So I kindly welcome you for this meeting, sir, and kindly take over this, sir. Thank you, sir.
Yes, sir. Good morning, sir. Sir, slides visible are there. Sir?
Yes, sir. Yes, sir. Visible arc, sir. Visible arc, sir.
Visible,
Sir.
visible. Visible, sir.
Good morning, sir. Respected Chairman, APA Trichy Chapter, Dr. Shivashankaran, Vice Chairman, Professor Anita Ma'am, and Secretary, Dr. Muthumani, and Joint Secretary Sivakumar, and office bearers. And also, I respect my senior APA members, Dr. Ashraf, Chennappan sir, Gunsegaran sir, and the National APA President Sethuraman sir. And my co-speaker, Professor P.V. Balamurugan. I thank Trichy APA for giving me this opportunity to talk on approach to peripheral neuropathy. The peripheral neuropathy is a common problem, but it has got diverse presentation and numerous causes, for which a logical approach is needed to diagnose this condition and the treatable neuropathies in some cases. So history is very essential, and general examination and systemic examination is very important. Of course, neurological examination will give clue about the nature of neuropathy. Before going to the topic proper, I will go with two cases. Before my talk, I pay my respect to the Institute of Neurology, where I did my DM training. Case number one, a 31-year-old male welder by profession. He presented with subacute onset symmetrical progressive weakness and benign sensation of 6 weeks duration, beginning in both lower limb, which extended up to mid-thigh, then both upper limbs from hands up to elbow. The symptoms got worsened over 6 weeks to the extent that he is unable to carry out his day-to-day activities independently. We elicited the history. He gave his history of glue sniffing for the past 15 years. He is from North Madras, which he had stopped 1 month prior to admission. So examination revealed severe hypotonia and wasting with flaccid weakness, distal more than proximal weakness with absent reflexes, graded sensory loss, both lower and upper limbs. Other cranial nerve and cerebellar were normal. So with this, we proceeded to investigate this patient with complete blood count, metabolic parameters, thyroid, B12, connective tissue markers, HIV, HCV, protein electrophoresis, which was not normal. The nerve condition study we did, which showed severe sensory motor axonal neuropathy involving lower limb and upper limb. Then we did sural nerve biopsy, which showed striking the segmental dilatation of the axons with first axonal degeneration, and the special stain which showed the dilated axon surrounded by thin myelin rings. The features suggest of giant axonal neuropathy secondary to glue sniffing. So this is the biopsy done at Nimmans. So this picture shows the segmental dilatation of the axons, and the F picture shows the dilated axons containing the phosphorylated neurofilament. So it's a case of toxic neuropathy, axonal neuropathy due to glue sniffing, which is called Badger's neuropathy. Case number two, a 20-year-old student who gave history of 2 years insidious onset of numbness over both left medial malleoli. Then it has progressed to involve heel, calcaneal area of the left sole, then lateral aspect of the left sole, then anterolateral aspect, and the shin of the tibia on his left leg. After 6 months, he gave history of slipping of his footwear from the leg left side. No trophic ulcers, no skin changes. There are no cranial neuropathies, no skin lesion. So the examination, general examination, physical examination, there was no nerve, no motor weakness. There was neurological findings suggestive of abnormalities of all modal touch sensation involving the distribution of the superficial peroneal, deep peroneal, lateral plantar, and calcaneal branch of tibial and sural nerve. The cutaneous examination did not reveal any lesions suggestive of leprosy, atrophic ulcers, or deformities. but there is a non-tender nerve thickening of the lateral popliteal nerve and posterior tibial nerve. So we proceeded to investigate this patient. So the diagnosis is the first case is a symmetrical polyneuropathy. The second case is mononeuritis multiplex. So for this, we investigated accordingly: vasculitic workup, protein chemogram, blood biochemistry, virology. Everything was normal. The skin smear from multiple sites for megavedrin lepre was negative. So we did nerve conduction studies which showed reduced map of left posterior tibial absence map of superficial peroneal, postural and lateral plantar nerves. So again, we did nerve biopsy, left sural nerve, which showed established the diagnosis of borderline leprosy, probably a purely neuritic type. So which is presenting as mononeuritis multiplex. So this is the nerve biopsy which shows the endoneurial granuloma composed of the histiocytes, histiocytes, and plasma cells. So this is a case of Hansen's neuropathy presenting as mononeuritis multiplex. The first case is blue sniffing, present as toxic sensory neuropathy and sensory and motor neuropathy. So the peripheral neuropathies are very common in 2 to 3% of general population, in which 8% patients are older than 55 years and 24% more than 65 years. Actually, the evaluation is time consuming, expensive. As I told you, there are numerous processes. Even after extensive evaluation, 30 to 40% are still idiopathic given after evaluation. So as all of us know, peripheral nerve includes cranial nerve, spinal nerve roots, DRG and nerve trunks, and the peripheral autonomic nervous system. The nerve approach is classified into motor, sensory, and autonomic, which is myelinated, and sensory we have myelinated and unmyelinated. Autonomic we have thinly myelinated and unmyelinated. So the large fiber mainly controls the touch, vibration, position sense, and the small fiber pain and temperature. And autonomic we know already. Again, the neuronopathy, which is a disease of the nerve cell body, where we have anterior cell disease, and sensory neuronopathy or ganglionopathy. So peripheral neuropathy, which is of disease process of neurons. We have axonopathies of disease of axons, and myelinopathies, which is of disease of myelin. A simple pathogenic mechanism. Demyelination, which involves the segmental degeneration, whereas the other two are Wallerian degeneration and axonal degeneration. So in Wallerian degeneration, there is reaction of both axons and myelin distal to the site of disruption. So it's a dying forward phenomenon, whereas axonal degeneration is a dying back phenomena, where the axons are affected progressively from distal to proximal. So the symptoms either positive or negative. So positive symptoms reflect the inappropriate spontaneous nerve activity, whereas negative symptoms reflect the reduced nervous activity. So the positive, the large fiber neuropathy produces mainly of negative symptoms in the form of loss of sensation and benign sensation, whereas the small fiber neuropathy produces positive symptoms in the form of burning pain, the paresthesia, lancinating pain, and the autonomic neuropathy, which produces reduced rating, urinary retention, hypotension, impotence, and vascular color changes. So we have to approach peripheral neuropathy by this way. There are three goals. One is this: what is the site of lesion, cause of the lesion, and the treatment. Then 6 key questions. What system is involved? Is it motor, say, sensory, or autonomic, or mixed? Then what is the distribution? Is it distal, proximal, or focally asymmetric or symmetric? But what is the nature of sensory? Burning, stabbing, or proprioceptive loss? Is there any pyramidal involvement associated? Then what is the temporal evolution? Acute, subacute, chronic, or preceding events, or drugs and toxins? And lastly, family history. We have to ask, because that will give clue on the hereditary neuropathy. Then 10 phenotype patterns: the symmetric, proximal, and distal with sensory loss and without sensory loss. Then symmetric sensory loss with or without weakness. Then asymmetric distal weakness without sensory loss. Then symmetrical distal sensory loss with distal rear flexure with pyramidal lesions. So what is the system here involved? So some peripheral neuropathies may present only with motor symptoms. So the exception to this rule is multifocal motor neuropathy, which is often normal sensory. We have predominant sensory neuropathies, mainly of commonly diabetes, thiamine deficiency, malignancy, leprosy, hereditary sensory neuropathy, amyloid, uremia, and Stargardt. Then we have motor neuropathies in the form of motor neuron disease, multifocal motor neuropathy. All other diseases, GBS, CADP, LED, all others have sensory signs on examination, but no symptoms. Then peripheral neuropathy with autonomic nervous system involvement, diabetes mellitus, amyloidosis, then drugs like vincristine, porphyria, and HIV-related autonomic neuropathy. Then what is the pattern of weakness? Is it distal, proximal, or both? Focal, asymmetrical, or symmetrical? So the distal symmetrical weakness is seen in axonal link-dependent neuropathy and demyelinating neuropathies. The symmetrical proximal and distal is the hallmark for acquired immune demyelinating like GBS and CADP. Whereas asymmetrical, acute or subacute sensory motor signs and symptoms indicative of radiculopathy, mononeuropathy, and mononeuritis multiplex. So peripheral neuropathy is often associated with pain. So what are the painful neuropathies? Where we have diabetes, vasculitis, amyloid, and toxic neuropathies like arsenic, thallium, and Fabry's disease. Then causes of the sensory neuronopathy, which is called ganglionopathy, common in Sjogren syndrome, drugs like cisplatin and vitamin B6 toxicity. Then associated motor involvement, motor neuron involvement, pure motor neuron involvement in case of the HSP, whereas the symmetrical distal sensory symptoms and signs suggest of distal sensory neuropathy with additional some UMN signs, which is called combined system degeneration and neuropathy. In case of B12 deficiency, we can have pyramidal and also large fiber involvement, and copper deficiency and severe hepatic disease we can have associated pyramidal. So what is the temporal evolution? Acute days to 4 weeks, the subacute 4 to 8 weeks, chronic is more than 8 weeks. Then is the course is monophasic, progressive, or relapsing? We have to ask all these things. So in acute onset, we have GBS and other acute intermittent porphyria and other causes. Subacute weeks to months, mainly toxins, paraneoplastic, and CIDP. And chronic, we have hereditary neuropathies, especially. Then relapsing remitting, we can occur in other conditions. So how will you find out hereditary neuropathy? It's a chronic, very slowly progressive distal weakness over many years. And patients with hereditary neuropathy often will present with foot drop. There will be no sensory symptoms. Then we have to look for skeletal deformities like a flat foot and hammer toes. So the genetic cause of the neuropathy should be considered with family history neuropathy, lack of positive sensory symptom, early onset, associated skeletal, and very slowly progressive course. Then we have to ask for occupational histories like our first case, then HIV, then recreational drug use and drug abuse, and childhood history of clumsiness or poor athlete performance suggests a hereditary cause. Then we have to ask for as usual diabetes, hypothyroid, and metabolic causes. Then drug history, we have to determine a possible temporal association between the agent use and neuropathy onset. The costing the effect of toxic neuropathy, where there's a symptom progression for months to year despite agent discontinuation, like our case. Then we have to ask for antibiotic history and B6 also. So examination, we have to look for vital signs like orthostatic hypotension in case of autonomic neuropathy, skin rash purpura for vasculitis, skin pigmentation for poems, oral ulcers for Behçet's. All of us know, I will just go through. Dry eyes, dry mouth for Sjogren and Sarkar, and lead lines in gum, knee lines in nails in case of lead and arsenic or thallium poisoning. Alopecia in case of hypothyroid and thallium. So curly hair, it is common in giant axonal neuropathy. Then skeletal deformities like Pescavus, typhus scoliosis, we have to look for HMS and neuropathy. Charcot joints, sensory neuropathy. Peripheral nerve thickening, common in Hansen's, HMS and neurofibromatosis. Orange tonsil in case of Tangiers disease. The examination, optic atrophy in case of inherited neuropathies, B12 and toxins. Then facial weakness in case of GBS. Trigeminal sensory loss in case of Sjogren syndrome. Then we have to examine motor system, reflexes and gait, and sensory, where we have large fiber neuropathy, where we have loss of joint position and vibrating sensation, and the reflexes will be absent, whereas a small fiber neuropathy, where the reflexes will be preserved with positive symptoms associated plus or minus autonomic disturbances. So the characteristic patterns of neuropathy, one is mononeuropathy, mononeuritis multiplex, and polyneuropathy. This picture, first picture shows the right median, left ulnar, and left common peroneal, which is where is called mononeuritis multiplex. The second picture shows the overlapping mononeuritis multiplex. The third shows the commonly presented as distal symmetrical polyneuropathy. The single peripheral nerve involvement commonly occurs due to trauma, compression, and entrapment. The common neuropathies in case of entrapment are carpal tunnel and the tarsal tunnel syndromes. It is nothing but multiple separate non-contiguous peripheral nerves, either simultaneously or sequentially, is the definition of mononeuritis multiplex. The causes of leprosy and vasculitic conditions, which requires urgent diagnosis. Distal symmetrical polyneuropathy is the most common variety of neuropathy. The majority of these cases are due to metabolic, toxic, and systemic disorders. So the neuropathy can be classified according to anatomic pattern. Then the size of the nerve fiber, large fiber neuropathy, small fiber, and mixed, as I told you. Then motor versus sensory, and large versus small, axons and myelopathy, as I told. So the myelin versus axon, the demyelinating neuropathy weakness without atrophy, which is a length independent pattern. They can have proximal predominant asymmetrical patchy involvement with the loss of reflexes. Whereas axonal, they have basting predominance, which is length dependent, more often distal reflex loss. So these are the patterns we have discussed. The lab test, the first line screening test for the neuropathies are blood count, ESR, sugar, metabolic factors. We have to do serum B12 and thyroid function test, vasculitic profile, especially if it is shorter duration. Urine studies, we have to do heavy metal screening, urine protein electrophoresis. Then distal symmetrical polyneuropathy, we have to do blood sugar, HbA1c, blood count, B12, and thyroid. Then immune electrophoresis. Test with the highest field of abnormality are blood glucose, B12, and immunofixation electrophoresis. Then potential etiology, what test to order, as we all know, for bad diabetes, B12 and paraproteinemias. We have to do in relation to the suspected diagnosis, like paraneoplasty, we have to do the corresponding serology. Then pure motor neuropathies. These are all among, we have to do CSF antibodies, multifocal motor neuropathy, we have to do other antibodies. Evaluation of myeloneuropathy. The patient has got both nerve and the cardiac involvement. We have to do spinal MRI. B12, again B12 level, copper and hereditary spastic paraplegia, we have to do genetic study. These things are, then in nerve conduction study, so which is helpful in documenting that the neuropathy exists, quantitating the severity, and whether it is distal, proximal, or diffuse. The next gives the motor and versus sensory, and where it is axonal or demyelinating type. So the nerve conduction studies shows where it is a demyelinating or axonal neuropathy in the form of latency and distal latency prolongation, whereas axonal in the form of CMAC reduction and nerve conduction velocity reduction. And is EMG needed? Sometimes EMG can differentiate acute denervation and chronic degeneration in case of pure motor neuropathies, where we can see fibrillations in positive ways. So nerve biopsy, it's not needed in all cases. A nerve biopsy is performed to evaluate asymmetric multifocal neuropathies, where in the second case, the nerve thickening, although we had nerve thickening, the skin smear is negative, all of the tests are negative. We did nerve biopsy, we showed the metabolite lepre. So in lower limb, commonly the biopsy nerve is sural nerve. Very rarely we can do radial in upper limb. So the American Academy of Neurology says that the nerve biopsy in the diagnosis of vasculitis, sarcoid, and CIDP, and leprosy. So it is rarely informative in distal symmetrical axonal neuropathies with toxic conditions. So the bedside atomic test, I'm not going to give a detail because all of us know. Then the skin biopsy in case of peripheral neuropathy is the standard assessment of unmyelinated cutaneous nerve. It can distinguish the neuropathy from radiculopathy because radiculopathy does not affect post-ganglionic fibers. The sweat gland nerve fiber density by skin biopsy with manual or automated analysis, which is useful in case of sympathetic pseudomotor innervation problems. Then very rarely we do other gymnastications like CT, chest, and other cases in case of malignancy, if you suspect paraneoplastic and other systemic diseases. So clinical presentation as neuropathy. If it is yes, is it focal? Then we have to do nerve conduction. If it is multifocal, then we have to find out if it is axonal or demyelinating. Axonal means it is bad. Vasculitis go for biopsy. Demyelination, mainly CIDP or hereditary neuritic palsies. If it is generalized neuropathy, mainly of acute demyelinating like TBS, and chronic we have the Charcot-Marie-Tooth disease and conduction block if it is CIDP or other HMS and type 2. So the management, the general principles, the specific treatment measures include blood sugar control with diabetes, and then reducing, removing the offending agents, correction of vitamin D deficiency and metabolic factors. Demyelinated neuropathies in particularly may be amenable to immunomodulatory therapies like IVIG or plasmapheresis. The symptomatic treatment includes various agents to control neuropathic pain. So what are the drugs which are available? Mainly gabapentin. These are the first line drugs for neuropathic pain. Gabapentin, the dose of 100 to 300 milligram TID. We can go for 400 milligram, we can increase, we can go up to this. The tricyclic antidepressants commonly used. Tramadol, duloxetine, and pregabalin is the FDA approved for diabetic neuropathy, which is 50 milligram TIV. And carbamazepine and other drugs of second line, opioid analgesics. The topical agents sometimes used capsaicin and lidoderm, which are used. So I conclude my talk. Peripheral neuropathy has numerous causes and diverse presentations. Hence, the logical approach is needed for positive effective diagnosis, especially of treatable neuropathies, for which a detailed history of the symptoms, family history, occupational history should be obtained. General examination and systemic examination provide valuable clues in our cases. Neurologic examination, of course, will say the nature of neuropathy. Lab investigations are carried out as indicated, and specialized tests are done in case of not all cases. Now that vaccine case of selected patients. But approximately 20% of patients with neuropathy remain undiagnosed, but the prognosis is not bad in them. So the neurologists fall into two polar groups. The pragmatics aiming at minimal possible investigation to solve the clinical problem. They usually work in secondary centers. The completists who aim to eliminate every possibility, however remote it may be, given it may not have a therapeutic application. Usually they work as experts in tertiary centers. So the pragmatists in secondary level are at risk of missing the rare condition, particularly if these mimic common conditions, whereas the completists are the tertiary care level physicians, neurologists are at a risk of misdiagnosis, as they may be misled by false positive results. So it is important to have a balanced view and follow the clinical and investigatory clues, possibility of therapeutic potential of the likely diagnosis. So it is recommended to do the right thing, but not everything. Thank you. Thank you for the question.
So thank you, sir. That was a nice lecture, sir, with all the practical algorithms and practical points for investigation and other things. Since it is a very common clinical topic, we'll be having a lot of doubts in this topic, sir. So as usual, we'll have the second topic. We'll finish the second topic and we'll go for the discussion, sir. So I request our second speaker, Professor Dr. Balamurugan, sir, to take over the session. And I request Dr. Prabhu, our Assistant Professor of Medicine, to introduce the speaker.
Good afternoon, all. So actually, I feel excited to introduce our own professor, Dr. P.V. Balamurugan, sir. Sir did his UG in Madurai and PG in Kilpak. And sir is well known for his sincerity and dedication. He has got a Best Doctor Award for 5 times, one in 2011 and 2012 while in Teni. And for last 3 years, he is getting Best Doctor Award. 2019 and 2020 while he is in Pudukkottai, and 2021 in Sivagangai Medical College. And sir also has made his contribution to many national and international journals and posters. And more than his excellence in profession, he is also a simple, friendly, jovial, and good-hearted person. Welcome to you, sir.
Thank you. Am I audible to you, Dr. Prabhu?
Audible, sir. Sir, audible.
Audible, sir, audible.
Okay. I'll just start sharing my screen. Is my screen visible, sir?
Yes, sir. Visible, sir.
Okay. At the outset, I like to thank the API chairman, Shivashankaran sir, and API secretary, Muttumani sir, and all API members. And I am also like to state my proud privilege to speak along with the renowned speaker and teacher, Dr. Mukundan sir also. Coming to this topic, which was given to me, that is ECG in neurology. The the heart-brain connection is always fascinating. And especially in this topic of ECG in neurology, you will find it more fascinating, and understanding this connection is very important in making a correct diagnosis. So today's agenda will be like this. I will be discussing the role of ECG in diagnosing neurological disease and illness, otherwise called cerebrogenic ECG abnormalities. And I will also dwell upon the role of ECG in cardiac diseases presenting to the neurology department. So the first part will be the main part, and the second part will be the minor part. So coming to the various neurological diseases which can present with abnormal ECG changes are hemorrhagic stroke, non-hemorrhagic stroke, acute encephalopathies, autonomic neuropathies, and seizures. Among this, hemorrhagic stroke presents with the most dramatic and most severe ECG changes, and even among hemorrhagic strokes, subarachnoid hemorrhage presents with the most dramatic findings, which can give us a diagnostic dilemma than the intracerebral hemorrhage. Coming to the hemorrhagic stroke, the both subarachnoid as well as intracerebral hemorrhages can present with abnormal ECG changes. As I said previously, hemorrhagic stroke presents with the severe and dramatic ECG changes, which you will see in the few more slides, which can mimic an acute MI. And the most common ECG changes are these three things which I have listed. Number one is the widening and inversion of T waves, especially in the precardial leads. They are called cerebral T waves. Next is the QT prolongation, and you can have a marked T wave QT prolongation to the extent that it can even lead to an torsides or even ventricular fibrillation, and also bradyarrhythmia. So whenever you have these three combinations in the ECG, it gives a high degree of suspicions that it could be due to an intracerebral problem. It can also lead to ST elevation, ST depression. Both can mimic cardiac ischemia. You can even have large upright T and also a prominent U wave. To make the diagnosis more difficult, in some of the subarachnoid hemorrhages, even regional wall motion abnormalities have been observed with ST elevation, and this is called neurogenic shunt myocardia. So it leads a lot of high degree of suspicion and a comprehensive history as examination to differentiate it from the coronary events. And this is a typical ECG. I have taken this from the Braunwald, 9th edition. You can see the T wave inversions so deep, as well as you can see that the T wave inversion, the base of the T wave is more broader. And this is the typical ECG seen with subarachnoid hemorrhages. If you have a doubt how to differentiate it from ischemia, this slide from Braunwald again gives us some idea. So you can see in the first ECG, V2, V3, V4 of ischemia, you can see the T wave inversion. And in the second the panel, you can see the cardiovascular event. You can see that QT prolongation as well as the bradycardia. So whenever you have that QT prolongation with bradycardia with a more wider splayed T waves, that goes in for the cerebrovascular accident. For comparison sake of T wave inversion, here the apical hypertrophic cardiomyopathy ECG changes with LVH is also being shown. So there can be a clue in the form of more wider T and also presence of QT prolongation along with this. So whenever a neurologist sees the ECG, if he misses that QT prolongation, that may be a problem. And coming to the non-hemorrhagic cerebrovascular accidents or strokes, they produce ECG changes which are less severe than the hemorrhagic stroke. There can be T wave notching with loss of amplitude. There will be ST segment elevation also in some patients. It can mimic acute pericarditis when it is diffuse, and it can mimic acute myocardial infarction when it is focal. Abnormal Q waves mimicking myocardial infarctions are noted. And apart from these repolarization abnormalities, any rhythm abnormality can be seen in stroke, ranging from sinus tachy, sinus brady, junctional rhythms, ventricular premature contractions, and ventricular tachycardias. So these are something which you should remember. And coming into this interesting thing, I read this during this preparing for this topic. Even acute encephalopathies can produce ECG changes. So in this case report published in Journal of Electrocardiology, a 20-year-old man presented with idiopathic acute encephalopathy. During his hospital stay, there was persistent fevers along with refractory seizures when treated with propofol. The serial ECGs showed marked ventricular repolarization prolongation with burst of tarsites, diffuse ST elevation, and even as a Brugada pattern. So you see these ECGs here. So this was the first ECG showing some non-specific T-wave inversion. So this is a baseline ECG of the patient, showing an QT corrected interval of 42 milliseconds. And later, you can see there is a junctional bradycardia with a deep QT complexes in anterior and inferior leads. And you can notice that tarsites is also present. This non-sustained tarside episode terminates with a fusion complex also, which is also marked by an arrow. So this is an interesting ECG seen in this patient presenting with encephalopathy. And even his ECG taken 6 hours after admission, they demonstrate junctional escape. You can also see the bigeminy rhythm, and you can also see the enhanced repolarization abnormality in second RR interval, maybe due to an abbreviated action potential duration. So you can see and even a pseudo RBB pattern. So these are some of the interesting ECG seen in acute encephalopathy. So ECG changes in CNS disorder can mimic an acute MI, acute pericarditis, and it can also mimic some of the drug effects. So whenever patient is taking some cardiotoxic drugs or even drugs when given in a larger doses, cardiac drugs, that you will have a doubt whether it is due to a CNS disorder or even due to the cardiac toxicity. So coming to this cerebrogenic ECG abnormalities, we know that these abnormalities occur for the past 60 years or so. And as I said previously, the most dramatic findings are seen in intracranial bleeds, and the prolonged QT increases the risk of tarsites, and it can even lead to sudden cardiac death. So some of the sudden cardiac death in a patient with the intracerebral bleed or intracranial events could be due to this prolonged QT. And these patients can also have supraventricular and ventricular brady and tachyarrhythmias, and also polymorphic VTs, which has been noted. Now coming to the mechanisms, what is the relation between the heart to brain? Though not one mechanism is being very much there are 2 or 3 mechanisms. The most common mechanism or basic mechanism is related to the alteration in the autonomic tone. And this alteration may be due to the raised ICP or intracranial pressure. That's why in a patient with a hemorrhagic strokes are more prone for this alteration in ECG. And also increased vagal nerve activity from the stimulation of the parasympathetic foci in the region of hypothalamus and medullary vagal nuclei could also contribute. And maybe this may be the reason in the patient with acute encephalopathy where there is a stimulation of the hypothalamus, as well as he is a susceptible individual, like there may be some genetic mutation in the sodium channels. They may be prone for these type of tarsites. And another one important mechanism causing the sympathetic storm is the heightened sympathetic tone happening in the patient with intracranial injury, has also been implicated in the ECG changes and some of the echo changes also. And also the ECG abnormalities, including the QT intervals and deep T-wave inversion in patient with certain neurological injuries, are not due to myocardial ischemia, but appear due to the excessive sympathetic stimulation. So alteration in the autonomic tone, increased vagal nerve activity, heightened sympathetic tone or STROM could be the mechanisms in many of these patients presenting with ECG changes. Now coming to the second part of the presentation, where patient is having a cardiac problem, but he lands up in the neurology OP or neurology ward. And one of the important causes is the cardiac syncope. We all know syncope is the most common mimic of seizure and will arise sometimes from the cardiac pathologies, which may be difficult to differentiate from epilepsies. It is not easy to differentiate every time whether it is a syncope or epilepsy. That is why the guidelines state that it is always important to take a 12-lead ECG in a first seizure clinic, which can give a crucial information. If the ECG shows an obvious or potentially serious arrhythmia such as VT or second or third degree AV block from emergency department, it is very clear that the cardiology problem is the reason for this syncope. But this situation, which I have put, it is a case history. Here, a 58-year-old female with a history of right MCO stroke with subsequent seizure disorder presented and got admitted with a one-day history of sudden LOC. She was found face down on the floor and unresponsiveness, but she recovered spontaneously. We don't know whether it's a syncope or we don't know whether it is a seizure with no convulsion being observed. Here, a simultaneous recording of ECG and EEG was done. And you can see this is the first ECG and EEG. Both are normal. You can see a baseline ECG of heart rate of 65 and you can see an EEG. And later, after admission, that previous ECG were taken before admission, baseline of that patient. Here you can see patient developing sinus bradycardia, and EEG is also associated with some of the frontotemporal parietal region slowing waves. There is a slowing of waves it's seen. And later, you can again see the heart rate still getting slower and slower. And again, the waves in the right frontotemporal parietal region waves are also getting more slow. So what does it indicate? So especially concomitant EEG can be very useful in diagnosing the cause of syncope. This is one term we should remember called ictal bradyarrhythmia or asystole. It can be essentially indistinguishable from vasovagal syncope, where you can see a tachycardia slowly going on to brady and even go to the extent of asystole. And in this case, this simultaneous monitoring made us to diagnose a case of ictal bradyarrhythmia leading to the particular condition, patient becoming LOC, and she had complex partial seizure of temporal lobe origin. So this is one thing where a simultaneous ECG and EEG can help. With these points, I would like to conclude with these take-home messages. Number one, the heart and brain connection should be always remembered and kept in mind. And when you treat only the ECG, there is multiple chances that you will be misled. A comprehensive history examination, which includes the past history and also a thorough examination and also a concomitant investigation like EEG and other metabolic profile can help in the most of the situation. And a physician should have a high degree of suspicion. And many studies tell training neurologists and physicians to interpret ECGs in this situation and is very much important. And we should never hesitate to consult a cardiologist in case of doubt, because some of the treatment can land up in the catastrophe. With these few slides, I like to thank the organizers of APA and Department of Medicine for giving me this wonderful opportunity on talking this topic. Thank you, sir.
Thank you, sir. It was a crispy talk, sir. You're sticking to the points and you have got some case illustrations also. And we'll go to the discussion. So participants can unmute yourself and you can ask your doubts to both the speakers.
Professor Mugun.
Yes, sir.
I'm Dr. Professor Perumal,
Yes, sir.
formerly physician, Rayapet Hospital. Hope you remember.
Sir, I know, sir.
Yes. One of my seniors, who is now at the age of about 80 years, had CA colon,
Yes.
undergone treatment, and he has recovered completely from the colon. Following the chemotherapy, it's a drug-induced neuritis. Now they labeled as S1 radiculopathy. Only problem is there is stability. Now he's undergoing alternative medicines, alternative physiotherapy, everything is there. There is no complete recovery. Occasionally, he tends to fall. What is it? It will be curable or not curable?
Sir,
Yes, so many neurologists in Madras.
Sir, is he having a radiculopathy or neuropathy, sir?
No, radicular. Now they labeled as S1 radiculopathy.
S1 radiculopathy means we have to look for the cause of S1 radiculopathy.
No, they say it is due to the chemotherapy induced.
So generally chemotherapy will produce neuropathy only, sir. If there is any due
No,
to
no. This is according to one of the leading neurologists who has given this diagnosis recently. So he has seen 3 people.
yes, sir. The radiculopathy can be a rare manifestation of this drug because the drugs will produce only small fiber neuropathy
Okay.
or other neuropathy. If there is any secondary deficits over the area where it can produce G1 root at the base spaces.
So CA is okay. There is no metastasis. Every year is undergoing the investigation. And the chemo, the surgeon who has operated seeing them or the chemotherapy.
Yeah, sir,
They don't come.
it is difficult to treat, sir.
That's what I want to know. I appreciate the last word you say.
Yeah.
Many things are not diagnosed, but it's not bad.
Yes,
This is the point I want to convey.
yes, yes.
We are defeated. We cannot assure we make them completely recover.
Yes.
There are a few cases like that. Thank you, doctor, for coming out this.
Sir, I did MD under your unit.
No, I know. Once when you were API, you met me. That time you were in Salem.
Yes, yeah.
Thank you, doctor. I'm very happy. I'm proud of you.
Yes, sir, yes.
You have gone so much.
You're in Chocklingam, sir.
Yes. I know that. I'm proud of you today. See, I purposely attending because to see you only.
Yes, sir.
I'm
Now you
very
are in
happy.
Trichy, sir.
Huh?
You are in Trichy now?
No. I'm Madras. My friend is there. He used to send me. I used to attend all the academic meetings.
Okay, sir.
I'm retired long ago.
Yes, sir.
I had an opportunity to do a PhD after 10 years of service. I was abroad in Malaysia for a long time.
That time, no, sir. Yes.
Malaysian Medical College was working after PhD, long time. Recently, when he came to India.
Yes.
Thank you, doctor.
Thank you, sir.
Very happy about your prognosis, your elevation. You deserve for that.
Thank you, sir.
Thank you. May God bless you.
Thank you,
Sir, Professor Mohandan, sir, one question, sir.
Yes.
Sir, the differentiation of small fiber and large fiber neuropathy, what is the clinical significance for this, sir? By differentiating a small fiber and large fiber, is there any difference we do in treatment, or is there any difference in prognostication of the patient, sir?
We have to ask history, and we have to look for findings to differentiate large fiber and small fiber, because the etiology is different, sir, for the large fiber and small fiber. As I have listed, the process of small fiber may be Tangiers disease, Sjogren, and other common problems. In large fiber also we have some specific process. So for that only we have to differentiate. But in commonly we see in diabetes and other conditions we have mixed. But in other conditions, like specific conditions, we have to classify, sir, as small fiber and large fiber.
Okay, sir. Thank you, sir. Sir, in diabetes, usually the patient will have the positive symptoms first, like a burning sensation and numbness, and later, after sometimes the patients will lose their sensation, sir.
Yes.
Sir, is the small fibers first involved and the large fiber later involved? Is it like that, sir?
It can be, sir, it can be not only small fiber first and large fiber next. It can be the other way also. So sometimes mixed also. Sometimes painful neuropathy also.
Okay, sir. Sir, what is the difference between neuropathy and neuronopathy, sir? One of the slides you have put, sir. Can you say about that little clear?
Neuronopathy is the dorsal root ganglia involvement, sir. Especially in case of Sjogren and other conditions, we have to go for dorsal root ganglia involvement. Motor neuronopathy mainly of battery hormone cells, which produces more the multifocal motor neuropathy and motor neuron disease. Sensory neuronopathy or ganglionopathy. The ganglionopathy is the lesion is in the dorsal root ganglia, not in the nerve.
Thank you, sir. Sir, this question is to Professor Balamurvan, sir. Sir, you said the cerebral T waves in subarachnoid hemorrhage. Sir, is this ECG finding incidental finding, or it has something to do with the prognosis of the patient? Like one patient is having a subarachnoid hemorrhage without ECG change, and another patient is having a subarachnoid hemorrhage with ECG changes. Is there any difference in prognosis or treatment or something like that?
Sir, actually, it has not been mentioned in any of the series, sir. So we don't know the exact link. But thing is that myocardium is not the primary thing. And these patients, if you still have a doubt, and even cardiologist not able, he may need a PCI to know whether he is having a coronary. Sometimes he may have a previous coronary issue also, now presenting with the CVA, and that sympathetic storm may be the reason. So there is not a mention, sir. No specific study has gone into this, and they have made out. So I'm not able to address that. Sir, Mukundan sir may be in a better position to answer this question.
Same, sir, whatever it is.
Sir Mohandan sir, you want to say something about this, sir? The ECG changes in subarachnoid hemorrhage, and is it related to prognosis or something, sir?
It is not necessarily to prognosis. So as he has told, there are lot of changes in ischemic and hemorrhagic behavior. The other way also, the patient will not necessarily neurological changes. Sometimes in cardiology also the thrombolyze for ischemic brain condition also thrombolyzed. So this thing, all these changes are well described in books and other conditions we see commonly.
Okay, sir. Sir, one practical question, sir. What we usually see in diabetic patients, so some patients more than 10 years of diabetics, severe neuropathy, the patient won't have any sensation in the feet, sir. The common thing they will complain is not able to feel the feet. And one more thing is they won't be able to hold their slippers, sir, during walking. So at this point of time, what is the treatment, sir? Whether it is possible to reverse this stage or it is very difficult, sir. Other than strict glycemic control, is there any particular treatment for this condition, sir?
Well, we cannot reverse it, sir. So what you are saying is severe motor and sensory neuropathy, sir. Motor neuropathy will produce this motor sensory. So I think that is almost after 10 or 20 years. So we can give only symptomatic treatment and physio for these limbs.
Okay, sir. Usually the symptoms, initially they will say that burning and burning sensation and painful, sir. At that time, we can give some gabapentin like that, what you told, sir. But at this point where they don't have any sensation, what drug can we give, sir? Is there any drug can we give to make them symptom free like that, sir? Is it possible, sir?
Sir, in case of this large fiber involvement, we can give other anti-epileptics like carbamazepine and other amitriptyline we can give.
Okay, sir. Sir, you said quinolones neuropathy. Quinolones is one of the cause for neuropathies in one of your slides.
For completion's sake, it is mentioned, sir, in the literature.
Okay. Okay, sir.
Very rare.
Okay, sir.
Dr. Mukundan, it was nice talk, Balamurugan from Salem.
Thank you.
Thank you for enlightening, and special thanks to Dr. Balamurugan also. And
Thank you, sir.
it's a really, the ECG changes in cardiac and neurological things are nice. And one more thing that I think you have mentioned, I might have missed the things. Sometimes patient can present with the dual problems, acute MI with acute stroke.
Sir.
That's one issue that double attack.
Double whammy.
Yeah. That's one thing. Second, sometimes when the patient is conscious on ICU, they can develop Takotsubo cardiomyopathy. That may mimic like acute subendocardial infarction. Sometimes we may be going with, when they have a tachycardia, we may be thinking it's a pulmonary embolism because of the GBS. Sometimes it may be a Takotsubo cardiomyopathy. I think you have enlightened everything in this slide. Thank you, Dr. Balamurugan. That was very nice.
Thank you, sir.
Thank you.
Sir Balamurugan, sir, one question in the chat box, sir. Is there
Okay,
any treatment for this QT prolongation in the TCG, sir? Is there any specific treatment for QT prolongation or prophylaxis for ventricular fibrillation in hemorrhagic stroke?
Sir, actually, these changes are primary changes like the coronary changes. And if you are very much sure that it is due to the secondary to the cerebrovascular events, there is no specific prophylaxis given, sir. So it is very important to rule out coronary events. Even primary coronary intervention can be done to rule out if it is still in doubt. Apart from that, based on the cerebrogenic ECG changes, there can't be any prophylaxis can be given, sir.
The only thing, Dr. Balavan, we have to be careful in adding the neurological drugs, especially
Okay.
eptine, lacosamide. When you see the prolonged QT, that's one primary indication, practical indication of looking at the ECG in those cases. Because neurologists may be adding either fozolin or eptine or sometimes lacosamide. Both the things are pro-arrhythmic in the setup of prolonged QT.
Okay, thank you,
That's
sir.
something
And
that we
many,
have to look. Thank you. Sure.
many studies they have mentioned that many times the ECG may look normal, but QT will be abnormal. And apart from the heart rate, you should also look at the QT. A slight prolongation of QT may indicate the patient is having cerebrovascular event, and the neurologist should be sensitized on this. That many studies have pointed out. Thank you.
Thank you, sir. I also thank Dr. Balamurugan, neurologist, sir, from Salem for contributing this academic session, sir. So, any participant want to ask questions? So, sir, one final question to Professor Mukundan, sir. Sir, what is the investigation that can be done, initial investigation that can be done to identify peripheral neuropathy, apart from the clinical examination, like looking for the vibration, like the pinprick and the thin monofilament? Other than this, any investigations, the next investigation to find out or to confirm peripheral neuropathy? Sir?
Do nerve conduction. We have to do nerve conduction.
Okay. Sir, about this biotheciometry, sir, is it about that biotheciometry, sir? In most diabetic institutes, what they do for all patients, they will do biotheciometry and they will give one report based on the numbers, sir.
Don't have any ideas.
Thank you, sir. Thank you. So, if there is no more question, I think it's time we can conclude the session. And for giving a vote of thanks, I request our Joint Secretary, Dr. Shivkumar, sir.
Thank you, Muthuani. Good afternoon to all. At the outset, I would like to thank our Secretary, Dr. Muthuani, for giving me the opportunity. First of all, I thank Professor Mukundan, sir, beautifully explained the two cases of symmetrical polyneuropathy and multiplex, and beautifully explained the approach with rule of 3, 6, and 10, and a wonderful explanation on clinical findings, etiology, box algorithms, as well as the management. The one depressing news is 30 to 40% of the time it is still idiopathic, and even with all set of investigation, 20% remain undiagnosed. That's a problem we met with in day-to-day practice. Thank you so much, Professor Mukundan, sir. Then next, Dr. P. Balamurugan, sir, is enormously explained about the ECG changes in cerebrovascular diseases. And it's beautifully explained in hemorrhagic stroke, non-hemorrhagic, and acute encephalopathy, cerebrovascular ECG changes. Only thing is, we missed so many things, especially in the presentation with, as Balamurugan said, presentation with in both time, acute myocardial infarction as well as in the hemorrhagic stroke. Especially when the patient developed the ICH hemorrhage during streptokinase therapy. Without explanation, some patients thrombolized with streptokinase then developed ICH. It's a problem we met. We got a beautiful ECG, sir. If at all we send your number, I send the
Okay, sir.
cerebral to you. Thank you so much.
Thank you, sir.
Finally, I thank Dr. Muthuani for giving me the opportunity. Thank you, sir.
The Sun Pharma Arian.
And finally, I sponsor the Sun Pharma area for giving the request to give the sponsorship routinely because it is very less cost when compared to the physical meeting. Thank you so much. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, Mukundan, sir.
Thank you for the opportunity.
Thank you,
Thank you.
Thank you,
Thank you,
Muthamani.
sir.
Thank you, Shiv
Thank you,
Kumar.
sir. Thank you, sir.
Good
Thank you, sir.
job.
Thank you, sir.
Nice. Thank you.
Thank you, sir.
Recording stopped.
Thank you. Thank you.